Bismillah. Today our first topic is heavy menstrual bleeding. Heavy menstrual bleeding is a very important guideline. Um, if I told you like third of last exam came from this guideline, I will not be lying. Almost like 20 or 30 questions came from this guideline alone. So this guideline is very important. I know nice guidelines for some people can be tricky. They cannot accommodate it, or they cannot understand it. So I tried my best to summarize it as much as I can. So, okay. So people with heavy menstrual bleeding, 20 to 35 of them will have adenomyosis, and 15 of them will have submucosal fibroid. So hysteroscopic myomectomy will improve heavy menstrual bleeding and will help avoiding pharmacological or surgical treatment in 70 to 80% of these people. As I told you in my previous messages, last exam, they haven't focused much on numbers, but at least know the numbers. The most common numbers are the ones that will be you will find in our questions when we are giving you questions. You will find that there are some numbers you should not miss, but these numbers you can overthrow it. Don't worry about it. Okay. So first, when a woman comes to you complaining of heavy menstrual bleeding, you have to take history from her. History should cover at least the nature of the bleeding, the related symptoms like pressure symptom, intermenstrual bleeding, pelvic pain, because this will lead you to the definitive diagnosis, because we cannot give her definitive treatment unless we know the diagnosis. Then the impact of heavy menstrual bleeding on her quality of life, the factors that may affect the treatment, like if she has other comorbidities or if she has been treated before for heavy menstrual bleeding, because we don't want to repeat the mistakes of the past. Okay. Then we keep in mind that menstrual cycle have a very wide range of natural variability. So you have to put this in mind and tell your patient this. So if this woman with a history of heavy menstrual bleeding with no other symptoms, we can consider giving her pharmacological treatment without carrying any examination, unless you will give her IOS, because you know IOS or Mirena, you have to have pelvic examination before putting a Mirena or any intrauterine device. Okay, so let's go. Who for whom we should do physical examination? I told you before we put a Mirena or before any investigation, because this will guide us more. If you found a pelvic mass, okay, maybe this is a fibroid, or a large uterus, maybe this is fibroid. If you found pelvic masses, maybe this is endometriosis. So according to what you will find by examination, this will lead you to do more investigation. Also, if this woman has other related symptoms, maybe she has IPS, maybe she has other problems beside her heavy menstrual bleeding. Okay, what laboratory tests should be carried? For all patients, full blood count. This must be done for all patients without any exception. The coagulation profile only for women with having heavy menstrual bleeding since they started their menstrual cycle, or she have a family history or personal history suggesting that she has a coagulation disorder. Never do serum ferritin female hormone testing, these should not routinely be carried out. But thyroid hormone carry out if there is other symptom associated, like she has other symptoms suggesting that she have problem with her thyroid function. Other than this, no, thyroid hormone should not be done. Investigation for the cause. Before starting any investigation, you can consider starting her with pharmacological treatment, as we said before. This can be done to a woman with low risk. When you did history and examination, found that she has a low risk. She don't have fibroid. She don't have a history suggestive of uterine cavity abnormality or histological abnormality or adenomyosis. So everything with this patient, like she seems like she's fit and well, but only she have heavy menstrual bleeding. You can start her in pharmacological treatment. The investigation, as we said before, you have to put in mind what she have else and what examination and investigation, what examination has led you through. If it led you through one path, this will lead you also for the investigation in this path. Okay, for a woman with suspected submucosal fibroid or polyp or endometrial pathology, what we will do? First is outpatient hysteroscopy. Look and treat, or see and treat. We have to see this lesion and then start treating it. So outpatient hysteroscopy. If this woman refused outpatient hysteroscopy, what we will do? We will go for hysteroscopy under either local or general anesthesia. Okay, this patient don't want hysteroscopy at all. I don't like hysteroscopy. This is not me. I don't want it. So we will do abdominal ultrasound, but we will tell her that this will not give us what we like. It has a limited value. Maybe we will miss something. Okay, so when we are doing outpatient hysteroscopy, we should advise the woman to take oral analgesia before the procedure, like paracetamol or non-steroidal. This will be enough. No need to give her any morphia or anything, just any oral analgesia. Then we use hysteroscopy, a miniature hysteroscopy with 3.5 mm or smaller diameter. Okay, let's go to the next. When to take endometrial biopsy. We are now seeing the cavity. There's abnormality. If we have a woman with persistent interministerial or persistent irregular bleeding, and women with infrequent heavy bleeding who are obese or have polycystic ovary syndrome. Also, women taking tamoxifen. We know that tamoxifen increases the risk of endometrial hyperplasia, and we will discuss endometrial hyperplasia inshallah later. So if this woman is taking tamoxifen, she is a high risk for endometrial hyperplasia. So let's take a biopsy. Also, women who took medical treatment and it was non-successful. We want to see why. Okay, never take a blind endometrial biopsy in women with heavy menstrual bleeding. This is the stepwise, as I told you. First, if we suspected this patient has submucosal fibroid or polyp or endometrial pathology, we first tell her we want to take outpatient hysteroscopy. If she refused, we will go for hysteroscopy under local or under regional or general anesthesia. Then the last step is pelvic ultrasound, and we have to tell her that this has a limited value. We will not get every information from this. Let's go to the next slide. Okay. If we suspected a larger fibroid, we will offer her a pelvic ultrasound. if the following applies, not to all patients, just if she has one of these three criteria. First, their uterus is palpable abdominally. What we mean by palpable abdominally? If it is palpable abdominally, this means that Dr. Aram says that he can't hear or she can't hear. Does anyone have the same problem with hearing? I checked before, and all of you told that the voice was clear. Is my voice clear or not? Anyone? Anyone participating?
Yes, yes.
Okay. Check your. Okay, I will respond. Connection. Okay. History. We will offer pelvic ultrasound for women with palpable uterus abdominally. If the uterus is palpable abdominally, this means it is more than 12 weeks pregnant. Like it is more than 12 weeks gravid uterus. So this is large. This is a huge. This is more than first trimester. So we have to do a pelvic ultrasound. We have to know why it is very large like this. If also history and examination suggested a pelvic mass, this pelvic mass may be another fibroid, but subserous, or it can be, like I said, endometriosis or whatever, other pathology. She has other pathology. Examination is inclusive or difficult. Like an obese woman, you will not be able to do a pelvic exam. So better to go for a pelvic ultrasound. Obese patients always have a problem with us. You will find this also for when we are monitoring this gas, more for gestational age. Patient with obese patient, we will go directly to umbilical artery ultrasound in the third trimester. She will pass all this. We will consider her as high risk. So yeah, this is one of the reasons to do a pelvic ultrasound. Okay, so now we are suspecting adenomyosis. First, adenomyosis, we will go not for a pelvic scan or abdominal ultrasound. No, we will go for transvaginal ultrasound, in preference to transabdominal or MRI. So transvaginal here is the gold standard. We will do it better than MRI and transabdominal. Okay, who are our candidates? Patient we have who have significant dysmenorrhea or bulky tender uterus. Bulky tender uterus most times equal adenomyosis. So a patient with significant dysmenorrhea or bulky tender uterus, this patient we will do transvaginal for her. If the woman declines transvaginal, we will consider transabdominal or MRI, but we will tell her also the limitation. Every time you choose an investigation, not the ideal or not the gold standard, always tell her about the limitation. This is not much more important now in part 2, but it's more important in part 3, because this is a communication skill. You have to tell her. If you don't tell her this and the investigation didn't get you anywhere, she will come and sue you. You didn't tell me that there was that this investigation is of limited value. You have to tell her everything to protect yourself. Sometimes adenomyosis will be associated with endometriosis. So maybe the pain is not due to adenomyosis, but due to endometriosis. So I'm telling you, if you suspect adenomyosis or even endometriosis, go for transvaginal ultrasound. Okay, let's go for the next. Other diagnostic tool, we are not using anything like saline infusion, sonography, or MRI as first line. No, these are not our first line. Our first line, either for this, is just transvaginal ultrasound. DNC alone is not a diagnostic tool. I know that most people in Egypt are doing this. We will go, okay, patient coming for heavy menstrual bleeding, okay, let's do a DNC. So no, DNC is not a diagnostic tool. What information should we give this patient? We will explain for levonorgestrel, IUS, or Mirena. We will explain about anticipated changes in bleeding pattern. We have to tell her that for the first few cycles or for the first 6 months, you will have a change in the bleeding pattern. Maybe you will bleed twice monthly. Maybe you will have less bleeding. Maybe you will have more bleeding. So we have to tell her this. And we have to tell her that we cannot judge this method unless 6 months have been over. Okay, we will have to tell her every patient coming, she is afraid of her fertility. What about my future fertility? We have to tell her that hysterectomy or ablation, you will lose your fertility. You will not be able to get pregnant again. But with uterine artery embolization or myomectomy, maybe you have the potential to get pregnant. Okay, for endometrial ablation, we will tell her to avoid subsequent pregnancy, and you must use an effective contraception. Okay, for hysterectomy, there is a special consent advice on hysterectomy, and inshallah we will cover it. So don't worry, we will cover everything, because every patient coming for hysterectomy, you have to have a long talk with her. So this we will discuss later, inshallah. Okay, management, how to manage a patient with heavy menstrual bleeding. First, we have to talk with the patient before agreeing to any method. First, we will have to take in our account her preference, any comorbidities, presence of absence of fibroids, polyp, endometrial pathology, adenomyosis, because all of this will affect our method of treatment. Also, we have to know other or take into account other symptoms like pressure symptoms and pain. Okay. If the patient have a if the patient have a no endometrial pathology and the fibroid is less than 3 centimeters in diameter, or suspected or diagnosed adenomyosis. So this treatment is for all those patients who have no endometrial pathology, or a fibroid less than 3 centimeters, or she have adenomyosis. We will first consider Mirena as our first line. Mirena is the first line here. Okay, then if this woman declines Mirena, we will go for, or if Mirena is not suitable for her, we will consider other pharmacological treatments. We have non-hormonal and hormonal. Non-hormonal, we have tranexamic acid and non-steroidal. And for hormonal, we have the COC, combined hormonal contraception, and the cyclical oral progesterone. Okay, for progesterone, only contraceptions may suppress menstruation, which may benefit her. But you know that progesterone only contraception, the main action is thickening the cervical mucus. Only drospirenone, I think, yeah, is the or the third generation is the only one causing the Cerazette. Cerazette is the only one causing suppression of suppression of ovulation. But most of them have the side effect of suppressing menstruation. Most of people, especially for this go, I'm talking about all the progesterone only contraception, not only the pills. For them, most people will come to you after like 2-3 weeks saying I have no period. So this is a common side effect with progesterone only contraception, to cease the menstruation. If the treatment is unsuccessful, or this woman don't want a pharmacological treatment, or her symptoms are very severe that she cannot withstand, here you know that NICE guidelines are for all medical personnel. They are targeting mainly primary care, so they are telling this to the GP. He have to refer her to a specialist. Who is the specialist? This is us. They have to refer her to us to do an investigation. Mostly heavy menstrual bleeding is treated as a GP patient, not as a specialist patient, but she comes for us for investigation. So first we can do investigation. We can prescribe alternative treatment, like other pharmacological treatments that have not been tried yet, or surgical option like second generation endometrial ablation or hysterectomy. Okay, for women with submucosal fibroid, consider hysteroscopic removal. We will talk about fibroid. Fibroid have a very, like, I think 3 or 4 talks. It's very important. We will cover them in the next sessions, inshallah. So we can go for submucosal fibroid. We can remove it hysteroscopically. Okay. So if this fibroid is more than 3 centimeters or more, we can, as I told you, they are talking about GB, so they will refer her to us, to a specialist. If pharmacological treatment is needed, while investigation and definitive treatment, we can offer tranexamic acid or non-steroidal. We continue using non-steroidal or tranexamic acid for as long as they are effective. As long as she have a benefit from them, we can continue using them. We have to take into account the size, the location, the number of fibroid, and the severity of the symptoms. We can consider one of these. Pharmacological, we still have non-hormonal and hormonal. For the non-hormonal, still the same, tranexamic and non-steroidal, but for the hormonal, he added more. He added allopurinol acetate. Allopurinol acetate we were not using in the previous condition, but here we can use. We can use Mirena. We can use combined hormonal contraception. We can use cyclical oral progesterone. Uterine artery embolization can be a very suitable solution for this patient, and also we can do myomectomy or hysterectomy. Okay, take a very take attention to this. Allopurinol acetate have a serious effect on the liver, so liver functions should be monitored for the first 2 treatment courses, and as clinically indicated in the line, in line with current prescribing. So we have to do it for the first 2 treatment courses. And if allopurinol acetate is indicated, we will give either in 1 course lasting up to 3 months, of pre-operative. I just got a notification from Zoom that our meeting is extended beyond the 40-minute limit. One course lasting up to 3 months of pre-operative treatment for moderate to severe symptoms of uterine fibroids. And for intermittent treatment, up to 4 courses of moderate to severe symptom. So for of uterine fibroid in adult women of reproductive age who are not eligible for surgery. So either we can give it 1 course or intermittent for up to 4 courses. This you will not. This part is not in the course of the guideline. You will find this back after you know this. It will NICE guideline will have some parts after the finish of the original guidelines. They will have like suggestion for trials and stuff. You will find this there. When allopurinol acetate is used for intermittent treatment on women who are not eligible for surgery, we can offer allopurinol acetate 5 mg up to 4 courses, as we said, for women with heavy menstrual bleeding and fibroid of 3 centimeters or more, and her hemoglobin is 102 or below, and we can consider it if her hemoglobin is higher than this. So for any woman whose hemoglobin is 102, we should offer her allopurinol acetate before treatment, and if her hemoglobin is more than this, we can offer this. Okay. Be aware that the effectiveness of pharmacological treatment of heavy menstrual bleeding may be limited if the fibroid is large. The more the size, the less effective the treatment will be. Prior to scheduling uterine artery embolization, we have to do MRI. And this is important and always coming in the exam. Every time before and after uterine artery embolization, you have to go for an MRI, to send your patient for an MRI. Okay? To have more information about the fibroid position, size, number, and vascularity. When we go for endometrial ablation, it's better to choose 2nd generation over 1st generation, especially when the fibroid is 3 centimeters or more. Okay, if the treatment is unsuccessful, if you give her treatment and it is unsuccessful, go for further investigation or alternative treatment. Pre-treatment with gonadotropin. Retreatment with gonadotropin releasing hormone analogs or allopurinol acetate before hysterectomy and myomectomy should be considered if uterine fibroids are causing large, are enlarged or distorted uterus. So allopurinol acetate or gonadotropin releasing hormone analogs, these will decrease the size of the uterine fibroid before the surgery. Okay. Route and method of hysterectomy. This should be individualized. Total. You can discuss with her total or subtotal, whatever you discuss with the patient. Oophorectomy only after informed consent. Don't do it unless you have a consent from your patient. DNC, as we said before, DNC is, we should not use it as diagnostic tool and also not for treatment. If dilatation is needed, like some non-hysteroscopic endometrial ablation or something, we should confirm that there is no evidence of uterine perforation or forced passage, and we should use hysteroscopy before inserting the ablating device to establish the condition of the uterus An ultrasound may be used to ensure correct uterine placement of the ablation device. If the device uses balloon, keep this inflated during the ultrasound scan. Okay, let's summarize what we said. I love this chart. This chart I found, it has, as you see, summarized everything we said. If a patient comes with heavy menstrual bleeding, we will go for history and examination, and the only investigation here is full blood count. We can add to it, as we said, we can add to it thyroid function test or coagulation profile if this patient have an indication for this. Then if heavy menstrual bleeding with no additional symptoms, so no abnormality suspected, or this patient has heavy menstrual bleeding with persistent intermenstrual bleeding or high risk of endometrial pathology, we will here maybe we will suspect submucosal fibroid, polyp, or endometrial pathology. We will go for outpatient hysteroscopy plus or minus biopsy, and we said before when to take a biopsy. If the patient decline, okay, we will go for hysteroscopy under general anesthesia or regional anesthesia, or pelvic ultrasound if she declines the hysteroscopy at all. If there is a pelvic mass, uterus is palpable abdominally, examination is inconclusive or difficult, or this suggests that there is a larger fibroid, so we will offer pelvic ultrasound, either transvaginal or transabdominal. Significant dysmenorrhea or tender bulk uterus with suspected adenomyosis, we will offer transvaginal ultrasound. If she declined, we will consider transabdominal or MRI. And as I said, if you consider another method other than the original method, you have to tell the patient that there is limitation. Next, this is the treatment or the management. First, discuss treatment option, taking into account the woman's choice and preference, desire to retain fertility or the uterus. So if she wants this, hysteroscopy will not, hysterectomy, sorry, will not be an option. Benefit and harm of the treatment, clinical consideration like comorbidities, multiple pathologies, size of the uterus, and whatever. We have either a fibroid less than 3 centimeters or no identifiable pathology or adenomyosis. So this patient, we will consider levonorgestrel, IUS, or Mirena as first line. If she decline or not suitable, or we will consider alternative, which is non-hormonal or hormonal. And if levonorgestrel IUS has failed, we will go consider referral to a specialized care, which is us, to offer more like surgery or something more. Or if she has from the beginning severe symptoms, she has to come to us. We will choose either go for investigation or alternative pharmacological treatment if not have been tried, or we can go for surgical, consider surgical treatment like second generation ablation or hysterectomy. If submucosal fibroids, hysteroscopic removal is better. If the fibroid is more than 3 centimeters, we first consider size, location, and number of and severity. And we should be aware that the medical treatment will have a limited value in this case, and they should consider referring this patient to us. Consider surgery, here myomectomy or hysterectomy, or consider uterine artery embolization or second generation endometrial ablation, or we can consider pharmacological treatment at any time. For the surgery, pre-treatment with GnRH analogs and allopurinol acetate will help us, will decrease the size of the uterus and the fibroid. If uterine artery embolization is suggested, prior to scheduling uterine, sorry, prior to scheduling uterine artery embolization or myomectomy, the uterus and fibroid should be mapped by MRI. So this is the end of this guideline. Anyone have a question on it, or we go for the next guideline? Okay. Let's go for the second. We will, okay, chronic pelvic pain. Let me share the screen with you. Okay. So the second topic is chronic pelvic pain. Chronic pelvic pain is important. Sometimes you will have questions from this guideline. But for the last exam, not much question came from this. The one after it is the more important than this. I'm not telling not to, you have to cover everything, but you have to have priorities. So we are prioritized. I'm telling you this in the beginning, so you can prioritize your study, which is more important than others. Because as you know, we have a lot of guidelines to cover. So first, the definition, it's intermittent or constant pain in the lower abdomen or pelvis of a woman for at least 6 months and not occurring exclusively with menstruation, because if it is exclusively with menstruation, this is a PMS, or with intercourse, so there is a pathology, and not associated with pregnancy. So with a known cause, with no known cause. Okay, it is a symptom, not a diagnosis. You cannot diagnose one as a chronic pelvic pain. No, this is a symptom of other medical or surgical condition. Etiological factors. This slide is not very important, but we will go through it very fast. Usually it has more than one component. May not be possible to identify the cause of it. As a definition of pain, we all know it: sensory or and emotional experience associated with actual or potential tissue damage, or described in those terms. Sometimes pain experience may be affected by physical, psychological, and social factors. These women will come to you with a hidden agenda. She have a hidden reason. Sometimes maybe she have a history of sexual assault. Maybe she has a home, family violence or domestic violence at home. So you have to give her time to explain herself. You have to take time to identify the reason behind this pain, because most of the time this pain may be psychological, not due to any reason. It's just psychological. Okay, as types, maybe because of the central or peripheral nervous system. We have two types of pain: acute or chronic. Acute, this is a fresh tissue damage and resolve as tissue heals. And chronic, this is there is additional factors that come besides the original tissue injury. Local factors like tumor necrosis factor alpha and chemokines may change peripheral nerve function and or stimulate normally quiescent fibers, resulting in altered sensation over wider area than that originally affected. Alternation in visceral sensation can be called visceral hyperalgesia, nerve damage following surgery, trauma, inflammation, fibrosis, or infection. may play a part in this process. There is also a neuropathic pain, which result of a change in the nerve itself, but not exclusively burning, aching, or shooting in nature. Okay. The second cause is the main cause. The main important cause for us is endometriosis and adenomyosis. Pelvic pain, which varies markedly over the menstrual cycle. Cardinal symptoms: dysmenorrhea, dyspareunia, chronic pelvic pain. Symptoms alone, poor predictor for this. Dysmenorrhea in adolescents, don't overlook the adenomyosis and the endometriosis. It can happen in this age group. So if an adolescent, keep in mind that maybe they have endometriosis or adenomyosis. The existence of pelvic congestion, it's a controversial, but yeah, it may cause it. Ovarian suppression is the most important part in this. It will help these patients recover. We can do it by progestogens or gonadotropin raising hormone. And although many symptoms complexes that like irritable bowel or pain perception itself may vary a little with the menstrual cycle, 50% will have a worsening effect with their menstrual cycle or with their period, but usually cyclical pain equals gynecological problem. IBS, yeah, they may have like exaggerated pain during the cycle or during the period, but mainly it is our problem. It is gynecological in nature. Adhesions, we have two types of adhesion. Either this adhesion will be fine or coarse. For fine adhesion, there is no evidence to support divisions of these. For coarse adhesion, yeah, we can, or dense adhesion, we can go for division. Adhesion may be asymptomatic and may cause endometriosis, caused by endometriosis, previous surgery, or previous infection. We have two main categories in these two main syndromes that can happen due to adhesions, which is residual ovary syndrome and trapped ovary syndrome. Residual ovary syndrome, this is a small amount of the of ovarian tissue after oophorectomy. Or trapped ovarian syndrome, it is a trapped ovary or retained ovary. Sorry for this. In which a retained ovary become buried in dense adhesion post-hysterectomy. This can be treated by removing of all the remaining ovarian tissue or suppression by GnRH analog. IBS and interstitial cystitis also can cause chronic pelvic pain, especially IBS. Most people, most those having IBS will come with a severe pain throughout the year. They will not feel comfortable at all. IBS can be the primary cause, the component of the chronic pelvic pain, or due to chronic pelvic pain. It can be cause or part or a result. Okay, women attending gynecological clinic, 50% of them have a symptom suggestive of IBS. A musculoskeletal pain may be a primary source of pelvic pain or additional component as well. Pelvic organ prolapse may be also a source of pain. Spasm of the muscle can be treated by botulinum toxin or Botox. Nerve entrapment, this is very, very important. Nerve entrapment can happen in a scar tissue, fascia, or narrowing of a foramen. It is highly localized, sharp, stabbing, aching, exacerbated by particular movements, persistent beyond 5 weeks, or occurring after pain-free interval. Incidence after finished teal incision is 3.7%. Psychological and social, as I told you before, is like sexual abuse, child abuse, domestic violence can all cause this, can be a cause of pain. Initial assessment, as I told you before, we have to give her adequate time. We should explain everything. She is coming to know what's happening with me. We have to tell her that there is a multifactorial involvement in this condition, and we have to look for the underlying cause. There will be a concern for her. She have this hidden agenda. You have to search for this. History, we have to first see the pattern of pain association with other problems like psychological or bladder or bowel symptoms, the effect of movement and posture on pain. Symptoms alone can help in diagnosis of IBS, and IBS have a special, I think it's a talk article for it, and we will cover it as well. Don't worry about this. It may be helpful to ask directly about past and present sexual assault. This is a very important point. Sexual assault is one of the main reasons or the main causes of chronic pelvic pain. It's helpful to keep a pain diary for 2 to 3 menstrual cycles. And if there is an additional symptom suggestive of any other or a history suggestive of a specific non-gynecological component, we should refer to the relative or the relevant health professional. These are red flags for IBS. If a woman comes complaining of IBS or abdominal pain after with these, this is a red flag. You should act very fast. This is a sign of malignancy. Bleeding per rectum, new bowel symptoms over 50 years, new pain after the menopause, pelvic mass, suicidal ideation, excessive weight loss, irregular vaginal bleeding over 40 years of age, or postcoital bleeding. Most of these are signs of malignancy. These are our red flags. You have to act very fast. Examination, we should have an abdominal and pelvic examination. Any focal, search for any focal tenderness, enlargement, distortion, or tethering or prolapse. The sacroiliac joint or the symphysis pubis may also be tender. Investigation, first screening for infection. All sexually active women with chronic pelvic pain, we should do sexually transmitted infection screening. Transvaginal ultrasound and MRI, very important. Transvaginal is very important to assess adnexal mass, also adenomyosis. It will help us to at least know the cause. One of the reasons we have said. MRI may lack sensitivity to in detection of endometriotic deposits. It may be useful in assessment of palpable nodules in the pelvis, or when symptoms suggest the presence of rectovaginal disease. It may also reveal rare pathology. Diagnostic laparoscopy was the gold standard, but now it's second line. Now we are going more for transvaginal better than laparoscopy, because as you know, laparoscopy may have false negative and false positive results. It is an invasive procedure, but transvaginal ultrasound or MRI are now way more important than this. Diagnostic laparoscopy is the only test capable of reliably diagnosing peritoneal adenomyosis and adhesions. Risk of this is 1 in 10,000. Also, laparoscopy, it has also a guideline in its own. We will explain it later, inshallah. Risk of bowel, bladder, and blood vessel, 2.4 per 1,000. 2/3 will require of these will require laparotomy. 1/3 to 1/2 of diagnostic laparoscopies will be negative, and much of the pathology identified is not necessarily the cause of pain. So it may be give you false positive or false negative results. It should be performed only when index of suspicion is high for endometriosis, and when patients have a specific concern, which should be could be addressed by diagnostic laparoscopy to assure your patient. Microlaparoscopy and or conscious pain mapping. This is a new proposed alternative, but still not being adopted widely yet. CA 125, also if the patient have one of the red flags, because we are now suspecting malignancy. Therapeutic options. Women who have cyclical pain should look. Therapeutic options, it depends mainly on the cause. When you know the cause, you will treat accordingly. Women with cyclical pains, we are suspecting endometriosis or adenomyosis. Therapeutic trial using hormonal treatment for 3 to 6 months before having diagnostic laparoscopy. IBS trial of antispasmodic amend their diet to attempt to control symptoms. Appropriate analgesia. If the pain is not adequately controlled, consideration should be given to referral to a pain management clinic or a pain management team. Ovarian suppression can be effective for cyclical pain, either with combined hormonal contraception or progestogens or danazole, GnRH analogs. As I said, it is, you know the reason and you will treat it. IUS also be considered even in adolescents. Non-endometriosis related cyclical pain can be well controlled by these treatments, the previous treatments. All of this is just a repetition of what we have said. Non-pharmacological modalities like transcutaneous nerve stimulation, acupuncture, okay, may be helpful. We don't have a problem with this. Dietary modification also can be helpful. Laparoscopic uterosacral nerve ablation is ineffective in the management of chronic pelvic pain, so don't do it. Okay, let's go for a summary. The summary of from Dr. Raba. Oh, I think Dr. Ruba. I gave you the links to her articles before. Chronic pelvic pain incidence was 1 in 4, 25%. Unknown cause in 50%. Second most common, most cause of gynecological admission or consultation, 20 to 40%. Third, 1/3 of referral, 25% reason of laparoscopy, diagnostic laparoscopy. Assessment should be to identify contributing factor, multifactorial, multidisciplinary approach. Adhesion, IBS 50%, and musculoskeletal pain. You can, I will put this in the group, don't worry. So we finished this as well. If you have any question, anyone have a question regarding this, or should we go for the last guideline in our session today, and after this we will start some. Our last guideline is very important. As I told you, you will get, sorry, let me just share the screen first. Okay, Yeah, it's up. PMS, both premenstrual syndrome. The first few slides are not very important in your management. They are just describing the types of PMS. You will not, this will not affect you how you will manage, because management of PMS, it is individual, based on it is individualized treatment. You will individualize your treatment according to your patient's complaint. This is definition: vast array of psychological symptoms, physical and or physical symptoms. So the timing rather than the type and the degree of impact on daily activity, this will support the diagnosis. Prevalence: 40% of women experience symptoms of PMS. Of these, 5 to 8% will suffer from severe PMS. 24% is the prevalence. Etiology remains uncertain. We have some theories. The first theory is that it's a woman become more sensitive to progesterone. So you should avoid anything that have progesterone in these patients. Also, some say that the problem is neurotransmitters like serotonin and GABA. That's why we are using selective serotonin reuptake inhibitors for the treatment. You can find this in the guideline. As I'm telling you, this is just the classification of it. It's not very important. You will not be asked the type of PMS in the exam. Also, this is regarding this. The diagnosis. Women should have a symptom diary for at least 2 cycles, and should be completed by the patient prior to beginning treatment, because treatment may alter the pain cycle that she has. GnRH analogs can be used for diagnosis for 3 months. If the completed symptom diary alone is inconclusive, and to allow why 3 months? Because we have to allow 1 month for the agonist to generate a complete hormonal suppression, then 2 months of symptom diary. We can use questionnaires like daily record of severity of the problem or the premenstrual symptom screening tool. Okay. Treatment may improve symptoms, therefore masking underlying PMS, but it can also create a pattern of symptoms like I told you before. This chart should be brought by the patient to any future appointment. She must get her pain diaries here. Symptoms diaries can sometimes be confusing and inconclusive in both, especially with women with variant premenstrual disorder. This is the pain diary. You can find it in the appendix of the guideline. Just have a look at it. It will not. Previously, yeah, I would tell you, like, you can get this in the exam. Previously, they could give you this in the exam and tell you to diagnose, but the new type of the exam, the computer-based exam, they mostly are not able to put a lot of charts. I think last exam we didn't have any chart, so that's it. You can just look at it to know what is going on. Okay, criteria to diagnose core premenstrual disorder. This is from PMS TOG. It is precipitated by ovulation. Symptoms are not defined, although typical symptoms exist. Any number of symptoms can present. Physical, psychological symptoms are important. Symptoms recur in luteal phase. Symptoms disappear by the end of the menstruation. You have a free week, symptom-free week. Symptom must be prospectively rated. Symptoms are not an exacerbation of underlying psychological or physical disorder. Symptoms cause significant distress and impact on daily activities. Aspects involved in delivering service to a woman with PMS: referral when a simple measure have been explored and failed, and when the severity justifies gynecological intervention. It's also like before, like heavy menstrual bleeding, it's a GB responsibility to deal with these patients. In women whose symptom diary demonstrate non-cyclical symptoms and underlying a psychiatric or somatic disorder, we should counsel a psychiatric. We should have a psychiatric counseling. How to manage a woman with PMS, a severe PMS, multidisciplinary team. Sometimes they will have a dedicated clinic for this. General practitioner is the key for everything. This is the management. If you know this, you know all you want to know or you need to know about PMS. This is the one coming in the exam. This is everything you need to know. First line, exercise, cognitive behavioral therapy. Dr. Maimuna, we are recording. Please turn off your video because we are recording this. It will be up for yeah, it will be put in YouTube. So we don't want any accidents to happen. First line is exercise. Look, not every patient we will start with first or second. Maybe we will start with the second line. As I told you, the management is individual. We will give the management on individual basis. So maybe you will start with high dose or selective serotonin reuptake inhibitor, or maybe you will start with estradiol patch. You will give according to the condition of your patient, but mostly we will start one of these: exercise, cognitive behavioral therapy, vitamin B6. Yeah, it can help, but most of our problems will not come very. This is for a light condition, not very much problems. You can start with this, or combined new generation pill, or continuous or luteal phase low dose selective serotonin reuptake inhibitors like citalopram or escitalopram 10 milligram. Here 10. High dose, you will double the dose, 20 to 40. Estradiol batch, we have 100 micrograms plus micronized progesterone. You cannot, yeah, we said that progesterone can aggravate the problem, but unfortunately you cannot give estrogen alone. Estrogen must have progesterone with it. That's final. You cannot give, if the woman have a uterus, you cannot give her estrogen alone. Micronized progesterone, they are saying that micronized progesterone may have less effect on the PMS than regular progesterone. And this is the dose. Or we can use estradiol batch plus IUS, because now the systemic effect of IUS is not as much as the oral. Third line is GnRH analog plus ADVAC hormone replacement therapy. You will suppress everything. Or you can use like continuous, this is what is the ADVAC therapy we will get. A fourth line is surgical treatment plus or minus HRT. Complementary therapies, conflicting evidence. Some have effect, some don't. There's I think a two-page schedule, a two-page table for every of them in the guideline. 36 to 43 have a placebo response. This is like I summarized the schedule, the table in this. You can screenshot it, and instead of reading all this table, this is just a summary of it. Okay, let's. So you have sorry. Exercise, it has some benefit. Reflexologue, some benefit. Also, you have here biloba ginkgo, whatever. This is, I think, this is a Chinese herb or something. Some benefit. Evening primrose, some benefit. Aquapuncture, some benefit. Balm lemon, some benefit. Curcumin, some benefit, and germ wheat, some benefit. This is calcium and vitamin D. Yes, so it helps. Calcium and vitamin D help. Vitex agnus catus. Yeah, it have some. Yeah, it helps. So we have two that have definitive help, and and the others have some benefits. Some also saffron, which is a very expensive herb. It's helpful. So these are. I think there is a question in the mock about this. Okay. Cognitive behavioral therapy and other psychological counseling it should be considered routinely for every patient. Hormonal medical management of PMS, cyclical modifying agents like COC or dosaprenone containing COC is better. And for optimum COC, per regimen continuous rather than like cyclical, use it continuous. And this we will inshallah we will I will tell you how to give a continuous regimen of COC in the contraception guidelines, inshallah. Percutaneous estradiol. It is cyclic. It is a percutaneous estradiol with cyclical progesterone. It is effective. And when treating women with PMS, alternative barrier or intrauterine, so percutaneous estradiol has demonstrated no contraceptive efficacy. So you have to have another method of contraception with it. Avoid return of PMS symptoms during estrogen therapy with progesterogenic protection. When using transdermal estrogen, we use the lowest possible dose. As we said before, this patient have one of the series for PMS is sensitivity to progesterone. Low level of levonorgestrel IOS can initially produce the desired effect. Micronized progesterone is better than the regular progesterone. Use continuous estradiol. If you use estradiol or estrogen alone, you have to add progesterone in order to protect the uterus. Okay. This is also this is the same but with more details. You can find all this in the guideline, but I'm telling you, if you know just the chart, you will know everything. Optimum regimen for prevention of endometrial hyperplasia. When treating women with percutaneous estradiol, Cyclical 10 to 12 days course of oral or vaginal, progesterone with levonorgestrel IUS, or when using short duration of progesterone therapy, or in case where only low dose are related, they should be a low threshold for investigation. The lowest dose of the shortest time should limit unwanted progesterogenic effect, and therefore an oral dose of 17 to 28 days days from 17 to 28. So we are giving only 11 days of progesterone. Safety of estradiol, insufficient data on the endometrium or premenopausal endometrium and breast tissue. How long can estradiol be used safely, and what is the risk of recurrence? Due to uncertainty of long-term effect of opposed estradiol therapy, treatment with PMS should be for women with PMS should be on individualized basis. As I told you, treatment of PMS is required as long as the woman have the woman's ovarian cycle continue. If she discontinues the treatment, her symptoms can come back. Efficacy and adverse effect of danazol. Although treatment with low dose danazol, which is 200 milligrams twice daily, is effective in luteal phase for breast symptoms, it also have potential irreversible paralyzing effect. Women treated with danazol should be advised to use contraception during treatment, as it has a paralyzing effect on female fetuses. Cyclic suppression may be achieved. Okay, so this is what we use for the precaution for using danazol. Okay, GnRH analog are highly effective in treatment of severe PMS. When treating with GnRH analog, it should be usually reserved with women with the most severe symptom, not routinely recommended. Okay, so this is only for severe patient. If GnRH analog therapy does not result in elimination of premenstrual symptom, a lack of efficacy suggests a questionable diagnosis. GnRH usually is the last resort and the best method of treatment. Add-back therapy. This is why we give add-back therapy. And when treating women with severe PMS using GnRH analog for more than 6 months, we have to use add-back therapy. If we are using, we can use either combined HRT or Tibolone, and the doses are in that flow chart we put before. GnRH analog for diagnosis, we said this before, we should give them for at least 3 months, 1 month to allow suppression and 2 months for symptom diary. Progesterone and progestogen. The best is micronized, as we said, the best is micronized progesterone or levonorgestrel IUS 52 milligrams. Non-hormonal medical treatment which is selective serotonin reuptake inhibitors should be considered on the first line as a first line pharmacological management. We will start with low dose, then we will go for the second line for a high dose. Efficacy have to shown to have low concentration of serotonin with their platelets and virus. So there is a theory, as we said, like there is an imbalance in the neurotransmitter, especially serotonin. That's why we are giving serotonin reuptake inhibitors. How we discontinue? We should discontinue gradually to avoid withdrawal symptoms. Abrupt withdrawal will cause gastrointestinal disturbance, headache, anxiety, dizziness, paresthesia, sleep disturbance, fatigue, influenza-like symptom, and sweating. Adverse effects like nausea, insomnia, somnolence, fatigue, and reduction in libido. Improved efficacy with other selective serotonin uptake inhibitor regimens. It's not this. All of this, as I told you, it's not this important. Diuretics, spironolactone can be used. And women should improve their in mood and somatic symptoms. Surgical management surgical management can be justified. Hysterectomy, bilateral oophorectomy have shown to be of benefit. So yeah, we can give them, no problem with that. And we can do hysterectomy and bilateral oophorectomy. Should the efficacy can the efficacy of the surgery be predicted? Women when treating women with PMS, surgery should not be complemented without preoperative use of GnRH, because this will tell us if this patient will benefit from this or no. If she is not controlled with GnRH, she will not benefit from this surgery. The role of HRT after surgical management. We said that we should give her, if she is less than 45 years, we should give her HRT. Okay. Endometrial ablation, oophorectomy, and hysterectomy alone not recommended, because our problem is with the progesterone, and this will not help us at all. Okay. Bilateral oophorectomy alone will necessitate the use of progestogens as part of any subsequent HRT regimen. This carry a risk of reintroduction of PMS. So we are between two healths. Either we will just remove the ovary. If we remove the ovary alone, we cannot give estrogen alone because we still have the uterus. So we have to give progesterone, which may aggravate the symptoms again. And if we remove the uterus alone, we still have the ovaries which produce progesterone, which is the reason for the condition. So if you are going for surgery, go for abdominal hysterectomy with oophorectomy, either abdominal or vaginal. But for me, I'm always remembering as tahbesu. Don't, it's me. Okay, so now we finished the discussion. We will start now with questions. If you want to participate in questions, please raise your hand or tell me. We want to participate, and let's do it. Just let me share the screen. Okay, share. We have a quick mock today, just 28 questions. So anyone wants to share, just tell me or just unmute your mic and start reading the question. This is our first question. Who will participate? Or should I choose by random? Okay. No one, sorry. Who wants to start? Okay. Let me read the question. And if you don't want to say it, just type it in the chat. Sorry. Okay, let's start. No one is willing to participate in the question. Okay, let me. Healthy 40. Okay. A healthy 40-year-old woman presents to the gynecology clinic with a heavy menstrual bleeding. History examination and the ultrasound scan suggests the presence of adenomyosis, but no other pathology. What would be considered the first line treatment? Okay, Dr. Zizo, she said C. Let's see if this answer is right or no. Yeah, is C. And we have the flow chart. You can go back to the flow chart and see what we said. Okay, question number 2. I'll give you time to read it. Okay. 35-year-old woman presents to the gynecology clinic with heavy menstrual bleeding, opts to have levonorgestrel IUS. She is warned of the possibility of changes to her bleeding pattern. For how long should be advised to preserve with any unwanted changes to her bleeding pattern in order to see the maximum benefits of treatment? I think we said this clearly in the session. How many months should we wait, and should we tell her that her cycle will be changed? Please.
6 months.
Yeah, right. Who said? You are right. It's 6. Yeah, 6 cycle. Yeah, this is 6 cycles. This is what we said in the session. Okay. So women offered levonorgestrel IUS should be advised of anticipated changes in the bleeding pattern, particularly in the first few cycles, possibly lasting more than 6 months. After 6 months, she should come for a consultation if it is more than 6 months. Okay. What proportion of women who have treatment with gonadotropin releasing hormone analogs for the symptoms of premenstrual symptoms or syndrome, will report an improvement? Okay, so Dr. Roa said A. You referred to A or what? Yeah. So I'm giving you your time. You can either unmute your mic and speak or write it in the chat. Okay, let's see. It's E, 60 to 75%, and this is the explanation. Several randomized controlled trials have demonstrated improvement of PMS symptoms with response rate to GnRH analog treatment between 60 to 75%. Okay, a woman returned to the clinic for a review following an endometrial ablation procedure and concomitant sterilization. She is dissatisfied due to ongoing symptoms. what are the main symptoms associated with post-ablation tubal sterilization syndrome? This is a guideline, sorry, this is a TOG article I didn't share with you, so I know this question we haven't discussed yet. So I'll move to the answer. Sorry, yeah. The cyclical pelvic pain and vaginal spotting, and this is a syndrome. It is a recognized complication known to occur in cases where sterilization is combined with ablation. The main symptoms are cyclical, unilateral or bilateral pelvic pain with vaginal spotting. The mechanism of pain is thought to be retrograde menstruation into the obstructed fallopian tubes, resulting in distension of the fallopian tube. The incidence varies from 6 to 8%. So this one I know we haven't discussed. That's why I moved to the answer. Okay, during endometrial ablation procedure, what depths? Also, another question we haven't discussed. Endometrial ablation procedure, what depth of myometrium need to be destroyed to prevent endometrial regeneration from basal glands? This was a very famous question before, but no longer, like for the past 3 years. It has not come in the exam, and it is 5 millimeter. Just know it like this. These were two articles. One for the surgical treatment of heavy menstrual bleeding. Two articles. If you want to look them up and read them, but really they are very, very difficult to read. And I'm telling you, for the past 3 months, so the past 3 years, no question came from these two talks that now we not routinely read them. Okay, the endometrium is known for its remarkable ability to regenerate. Full thickness destruction of the endometrium along with superficial myometrium to 5 mm, which contains basal endometrial gland, is required to stop menstrual flow. Regeneration from these basal glands is often a reason for treatment failure. I'll try to have I have a summary for them. I'll try to give you a quick read with them, but next session, inshallah. What is the primary aim for medical intervention in the management of heavy menstrual bleeding? Why we will give her medical intervention first? To improve hemoglobin level, to improve serum ferritin level, to improve quality of life, to reduce blood loss as assessed by menstrual calendar, to reduce blood loss as assessed by pictorial charts. First, we are not measuring. Yeah, we have a hemoglobin basis, but we are not giving for this. This patient's main problem is that she have a lot of bleeding. She cannot function in her life. So the main reason is to improve the quality of life. This is the main reason for this. Yeah, this is not mentioned like so in the guideline, but you can just guess it. It should be recognized that heavy menstrual bleeding has a major impact on a woman's quality of life, and intervention should aim to improve this rather than focusing on blood loss. Okay. So this is extended matching, one of the worst exam questions. But really, if you have an answer in your head, you will not be confused. Just have an answer and look for it after this. For each of the following clinical scenarios, what would be the most appropriate treatment option from the list above? And this is the list. And don't read the list. This is my advice to you. Go for the question first, have an idea in your mind, then go for the list, not the other way around, because if you read the list, you will get confused. Okay, so we have we need the most appropriate treatment. The head of the question is very important. Sometimes they will, in the exam, sometimes they will put a case scenario in the heading, and after this he will alternate some symptoms. Okay, let's go for the first question. A 38-year-old woman with heavy menstrual bleeding is seen in the gynecology clinic. Her medical history is unremarkable. Other than mild renal impairment, the woman is keen to avoid hormonal treatment. So this woman, she have a heavy menstrual bleeding. Also, she have a renal impairment, and she don't want hormonal treatment. What first line will you give her? We go back to the chart we discussed. You will see that, yeah, first line we will go for pharmacological treatment. But which pharmacological treatment would benefit this patient? It is tranexamic acid. We cannot use non-steroidal because she already has a renal impairment. So non-steroidal will not be of benefit for her. Okay, let's go for the second question. 35 years old woman attends a gynecology clinic with heavy menstrual bleeding as well, and dysmenorrhea. So we have an added symptoms with which is dysmenorrhea. Her history is otherwise unremarkable, but a pelvic examination demonstrates an enlarged uterus with possible fibroid. Pelvic ultrasound scan is arranged, but the woman is desperate to start treatment. So we said that we can start medical treatment while waiting for the results. So which one of these we will use? These are the options. Choose one. Okay. Combined. Okay, we have here an answer with combined oral contraception. Let's see. No, dysmenorrhea means we need to go for non-steroidal. It's better to go for non-steroidal. And she said, it's better for this patient to have a non-steroidal. We will not give hormonal contraception while we have a possible fibroid. We need first to first line, we will just use either tranexamic or non-steroidal, and mefenamic is a non-steroidal. Okay, 37 years old with BMI of 38 kilogram per meter square, returns to the clinic for a review. She is a para 2 and her family completed. So she is 37, completed her family. Her husband has a vasectomy, so she has no intention of getting any patients in the future. 6 months earlier, she had a levonorgestrel IUS inserted for heavy menstrual bleeding. So she already passed the 6 months mark, we are telling her, but this has recently been removed by the GB for persistent vaginal bleeding, so she didn't benefit from it. Now she is coming for a definitive treatment, but this has been removed by the GB due to persistent vaginal bleeding. Prior to this, she had already tried tranexamic. This is the post medical history, is the post treatment. She could took tranexamic acid, mefenamic acid, so she went for almost most of the preventive, most of the medical treatment. Previous pelvic exam suggests an enlarged uterus equivalent to 9 weeks of gestation. Subsequent ultrasound demonstrate multiple small intramural fibroids less than 2 centimeters. What will be your choice? Let's go back to this chart. Okay, so she has multiple fibroids. She already tried the non-steroidal and tranexamic acid. She already tried IUS and it failed.
Hysterectomy?
Hysterectomy. Okay, let's see. No, he went for myomectomy, endometrial ablation, for second generation endometrial ablation. Yeah, endometrial ablation, as we said, she will not retain her fertility, but we will at least preserve her uterus. Okay, and endometrial ablation is one of the methods we can treat fibroids with. Okay, this is another MQ. For each of the following, what would be the next most appropriate investigation? Okay, so we will go for an investigation. 39 years old woman with BMI 40 attends the gynecological clinic with heavy menstrual bleeding. So this one is an obese. She is coming for heavy menstrual bleeding with heavy menstrual bleeding. Medical history unremarkable. Full blood count taken by the reference GB was normal. Examination is difficult due to the ovarian size. Which will we go for? This one we stated clear.
Ultrasound?
Yeah, this patient, we should go for pelvic ultrasound. We cannot do anything else for her. Only thing possible is pelvic ultrasound. Okay, 27 years old woman attends the GB surgery with heavy menstrual bleeding that is affecting her quality of life. Her history and examination are unremarkable. So she have heavy menstrual bleeding. She is 27 years old. What is the first line of investigation? Let's go back here. First line investigation is what? We have two things we can go for. Either for a full blood count, this is with examination we have to do it, and also we have to go for biopsy, sorry, not biopsy, outpatient hysteroscopy, but I cannot see it here. Is it here? I can see it here. Yeah, hysteroscopy.
Full blood count.
But yeah, either this. So for me, I'll go either for full blood count or hysteroscopy, but it should be outpatient hysteroscopy. So let's go and see. Yeah, he first chose full blood count because this is the basic. This with the before any investigation, this goes with the examination. It's part of the examination to do a full blood count. Okay. 44 years old woman presents to the clinic with heavy menstrual bleeding as well, and intermittent but ongoing intermenstrual bleeding. Her smear history is normal, so he already did a smear for her. She described recurrent episodes of vaginal thrush, but has no other medical problem. So what? For me, I'm suspecting there's something either local or infection. So cervical smear he already did and it was normal. we cannot go for coagulation test. It's not applied here. CT is not an option. Both of those not now. MRI not an option. So what? Serum ferrit no. Serum follicle no. Serum estradiol, 3-dimensional ultrasound, thyroid function. What do you think? N, I see here an N. Thyroid function for the thrush. She have a let me see, vaginal thrush. Vaginal thrush is mostly infection. I don't know, hysteroscopy. He went for hysteroscopy to see if there, what is the lesion, what is there to, what is the cause, or what is this thrush. So he went for hysteroscopy. Okay. So this one is clearly PMS. You can know what he asking about from the options. Okay, most appropriate treatment. 28 years old woman presents to clinic with PMS. She subsequently returns for a review appointment after 2 months of completing symptom diary, but the completed diary does not give a clear diagnosis. So we should go for what treatment should be considered for 3 months. He even made it very clear. Now you can, it's very clear what he is urging you to do. You have a symptom diary which is inconclusive, and he wants something to be done for 3 months. What is this? What is the investigation? Here it's both investigation and treatment. What is it? We said it clearly. Anyone have an idea? We said this clearly. If a patient have a symptom diary and it's not conclusive, we have to give her GnRH analog for 3 months to make the diagnosis clear. We said it. Now I'm upset. We said this clearly. Okay, an otherwise healthy 30-year-old woman with BMI 24 has completed symptom diary. This is strongly suggestive of PMS. So we don't need this GnRH. She already has a PMS. What would be considered first-line pharmaceutical treatment options? We have 2 first-line pharmaceutical treatment options, either hormonal or non-hormonal. We can give her combined, or we can give her low-dose selective serotonin reuptake inhibitor. Do we have here a low-dose selective? He only put it as selective, and we has a drospirenone containing combined, or so one of these can be the choice, and he used drospirenone because he didn't specify for the selective serotonin reuptake inhibitor if it is a low dose or a high dose. Yeah, you are right, Dr. Zir. You are right. Okay. 42-year-old woman with severe PMS opts to have laparoscopic bilateral oophorectomy following failed medical management. She only removed the ovaries. She declines to retain her uterus. She decides to retain her uterus and has commenced transdermal estrogen therapy. What would be considered the optimal first line for endometrial protection? We have one of two. Either we will use what or what. You have two options here to help her. We have two options here to help this woman. What progesterone you will choose? You can go for micronized, or we can go for, let's see. We have two options, either levonorgestrel iOS 52 mg, or we have a micronized, we can give her micronized progesterone, and both options are here. So let's see what he went for. He went for the micronized progesterone because I think because the iOS also didn't specify which amount exactly. Okay, I think this is also PMS. I know PMS questions are very are not like they are not good, but let's see. Yeah. Okay. First line pharmacological treatment as well. Let's go. 22 years old woman presents with an 8-month history of significant intermittent abdominal pain. Her menstrual cycle is irregular. She has noted an increased frequency in passing stool. The pain seen to improve after defecation. This is not a PMS. This is a chronic pelvic pain. She has a chronic. Yeah. What is your diagnosis in this case? What is the professional diagnosis? What does she have?
IBS.
IBS. Yeah. So what is the first line treatment for IBS?
Anticonvulsant.
What? You have these are the options. Choose one. I know that IBS, I said we will discuss IBS again. But let's go. Mebaverine is the treatment of choice. I know we have not, this is our first session. We have not explained this. We will explain it, don't worry. But know this, that the first line of the treatment for IBS is mebaverine. Okay. 20 years old woman presents with a 2-year history of chronic pelvic pain. The pain is present on most days, but is worse around the time of menstruation. She has noted that her stools are more firm than previously. She does not have urinary frequency. So, what treatment will you give this patient? She has a chronic pelvic pain, and the pain present on most days, worse around the time of menstruation. She has noted that her stools are more firm than previously. She does not have urinary frequency.
Laxative.
I'm hearing laxative. Okay, let's wait a minute. I'm just doing something on my computer. Sorry for this. No, this patient, she has her pain around the menstruation, worse around the menstruation. So we are suspecting here what we are suspecting something gynecological. We said that mostly if the symptoms are worse during the time of menstruation or around the menstruation, so this is a gynecological problem. Most probably it will be endometriosis, because also it have other it's starting to affect her bowel as well. So this patient, we will treat her as endometriosis. We will give her COC, combined hormonal contraception. Okay, so first have a diagnosis. Know what is this patient, what's her problem first. After this, you can go for a treatment. Okay, so suggestive. So look, he is saying here that this patient have a symptom suggestive of endometriosis. As I said, she does not meet the criteria for irritable bowel. Therapeutic trial of hormonal treatment should be offered. So, as I told you, okay, 30, and he didn't give her danazole or GnRH agonist because she is 20 years old. This is not appropriate for her. Okay, let's go for the next. 30 years old woman with BMI of 25 present to the clinic with cyclical pain as well, and ultrasound is normal. At her insistence, a diagnostic laparoscopy is performed, which show no obvious pathology. She has completed a symptom chart which show a distinct cyclical pattern of her symptoms. Okay. This question have a trick. Laparoscopy, and this we will say this when we are talking about endometriosis, that not all cases with endometriosis will have a positive laparoscopy. Most of them will have a negative laparoscopy, but if you're suspicious, if your clinical sense tell you that this is mostly endometriosis, go with your sense. So this patient as well, we will treat her as if she has an endometriosis, and also we will give her the same treatment, combined oral contraceptive. Okay. Ovarian suppression can be effective treatment for cyclical pain associated with endometriosis. Okay, so he is considering here as endometriosis, as I said. Not all patients with negative laparoscopy will be endometriosis free. Okay, this is the trick in this question. 45 years old woman is referred to gynecological clinic with history of menorrhagia, dysmenorrhea, and both history of premenstrual syndrome. Her hemoglobin is 11, and pelvic ultrasound scan is normal. All the options and of management are discussed with her in the clinic by a specialist registrar. She wishes to have endometrial ablation for treatment. All the statements regarding hair counseling this woman are true, except subsequent pregnancy should be avoided. Further contraception will be necessary. Dysmenorrhea will be relieved. Premenstrual syndrome will not be relieved. Approximately 20% will have no benefit with endometrial ablation. As also, this is from the medical, so the surgical management of heavy menstrual bleeding. I'll go for the answer. The answer is dysmenorrhea will be relieved. This is the right answer. No, dysmenorrhea will not be relieved. Okay, sorry, I'm sorry for this. Medical management of fibroid is best indicated when to give a medical management for fibroid. If the fibroid is less than 3, not distorting the cavity and asymptomatic. Fibroid is less than 3, distorting the cavity and asymptomatic. Fibroid less than 3, not distorting the cavity and causing heavy menstrual bleeding. Fibroid is more than 3, distorting the cavity and asymptomatic. Fibroid is more than 3, not distorting the cavity and asymptomatic. First, let us agree on something. If fibroid is asymptomatic, we will not do anything with it. So anything with asymptomatic, we will not choose, because asymptomatic fibroid has no treatment. We will not treat asymptomatic. C, yeah, for me it's C, because asymptomatic fibroid, whatever the size, we will not treat. Leave her. Once it is symptomatic, we will treat. Okay, put this in mind. Asymptomatic fibroid, you will not do anything with it. Keep it as such. Most people have asymptomatic fibroids and going on with their life without any problem. Okay, the incidence of chronic pelvic pain in women of reproductive age group is what? I know I'm bad with numbers, and I know that all of you are bad with numbers. So it's 15 to 25%. Okay. This is the explanation. Chronic pelvic pain is common condition. Current data from the USA and UK suggest that it occurs in 14 to 24% of women aged between 18 and 50. Less common it is a common condition at the population level. Further work has indicated that rate, but it's 14 to 24. I'm bad with numbers, and I know most of you are the same. The commonest pathology identified at diagnostic laparoscopy in patients with chronic pelvic pain is what? This is look, as I told you, laparoscopy have a very high false negative results. So that's why we are not using it anymore, because most of the people, you will not find anything, but they still have a problem. So my answer for me, no, Dr. Zizo, is not A. For me, I'm going with no pathology detected, because this is what is the most cases we will not find anything. Everything will be normal, but this patient will be suffering. That's why we are not using it anymore. Okay, keep this in mind. We are not using it anymore. Why? Or we are putting it as a second line, because we will not detect anything. Even with a high suspicion of endometriosis, there's a lot of cases you will not find anything with laparoscopy. Okay, so let's go to the explanation. Increase order, okay, adhesion 24, typical, sorry, 24% will find adhesion, 33 endometriosis, no pathology in 35%. This is a very high percentage. So no pathology is the answer. Okay. In the use of selective serotonin uptake or serotonin noradrenaline reuptake inhibitors for treatment of the severe PMS, all the following statements are true except. Possible side effects include nausea, insomnia, and reduction of libido. Should be considered as first-line pharmacological intervention for severe PMS. Should be withdrawn gradually when given full cycle to avoid withdrawal symptoms. There is good evidence that it can be combined with hormonal contraceptive for better control. Total premenstrual daily symptom report score were better with luteal phase dosing than full cycle dosing. Okay, first is A is yeah, this is right. We can consider it as first line choice. We can give her high dose. We should withdraw it gradually. I don't know about this, but this, yes, I think it's D. For me, it's D, yeah. And this, I said it in a hurry, but I said it during the presentation. All nausea, insomnia, and reduction of libido, all of these are side effects. We should withdraw gradually, and we said why. And first line, yeah, it is the first line, but in severe PMS, we can give the high dose. And for total for this one, I didn't mention, but it was written in the presentation. Yeah, so it is D. Okay, you can screenshot the explanation if you want. Okay, let's go for 24. Okay, this is what I told you about. I told you that this table will come. There is a question about it. Of the following complementary therapy options, choose the one with evidence of effect in the treatment of premenstrual syndrome.
B.
Yeah, ginkgo biloba, no, magnesium. I don't know why, but ginkgo biloba, this one also. Let me check again. Let me, after we finish, we only have for oh, Dr. Nagat, you are welcome, Dr. Nagat. You are too late. We have only 4 questions left. Oh, okay, let's go for the next. Oh, this is not 4 questions. This is the last question. I'm sorry. I thought they were 28. This is the last question. Let's go for this question, the last one. Let me go back to it. It was in the yeah, PMS. Let's go. Yeah, this is the table. Magnesium has a mixed results. I don't know. Okay, let's just. I will show you. Yeah. Go. Yeah. This share screen. Magnesium has a mixed results. We said this. Magnesium has a mixed result. The only one which have a true benefit is either calcium or vitamin D, Vitex agnus, or saffron. Biloba ginkgo has some benefit, but this one, magnesium, no, it has no effect. It have a mixed result. So no. This one, this question key is wrong. Look back to this, and you will see that that this question is wrong. So no, the key is wrong. Look back to. You can also, maybe I copied it wrong, but please go back and check this question, because as we said, no, it's magnesium has no effect or has a mixed result on it. Okay, so that's all. Thank you, everyone. We will